Hi, welcome to NurseEdScholar. So by now, you know how to interpret labs. You know what potassium means. You know what creatinine means. You know how fluids affect labs. But the NCLEX doesn't ask you what a lab means. It really asks, what should the nurse do next? Okay. So today we're going to pull together everything, for this series, fluid electrolytes and ABGs. And I'm going to provide full NCLEX style scenarios. Now, it's just more or less to kind of get you to understand and see the pattern, okay? That mirrors exactly how the exam thinks. All righty, so let's start. So, how does the NCLEX expect you to think, right? So before I start these case studies, lock in this framework. The NCLEX expects you to ask in this order. Is there a dangerous lab pattern? Is the patient stable or unstable? Does the ordered the order intervention help or harm the patient? So if you provide that medication, will it help or harm the patient? And what action protects the patient right now? Because this is clinical judgment. That's exactly what you're doing, asking those questions. Because NCLEX isn't concerned about task completion. Okay? So let's start. All right, scenario one. Your patient has chronic kidney disease. Their potassium is 6.4, creatinine 2.9, and they're hooked up on a telemetry monitor and you see peaks T waves. Okay. And then there's an order for potassium chloride IV infusion. So you're gonna be like, wait, hold on. And what are you gonna ask yourself? What's the red flag lab? Well, the potassium, it's 6.4. And so you're like, okay, so what system does this affect? It affects the heart. So we always want to protect the heart. And does this medication help or harm? Well, the patient is already, they have hyperkalemia and potassium, IV infusion is going to make it worse. So what do? You hold the potassium. You notify the provider immediately. Remember, I always say you can always hold the medicine and give it later, but once you give it, you can't take it back, right? So remember, nurses do not carry out orders that place the patient in immediate danger. We just don't do it. You know, you hold the medication and then you document and explain why you didn't give it. Okay. All righty. So scenario two, here's the patient data. Their blood pressure is 86 over 50, so that's low. The heart rate is 122. Oh boy. The urine output is 20 milliliters an hour, and their sodium is 152. So here you have a low blood pressure, you have a high heart rate because it's trying to circulate the blood that they have. The kidneys, they're not perfusing. Look, 20 milliliters per hour. Normal, it's 30, right? So they're not even putting out enough urine. And the sodium is 152, so it's high. So that lets you know that it's concentrated. So, and then there's an order for IV furosemide. So furosemide is the generic name. Lasix is the brand name. So let's walk through this. So what do the vital signs show you? It shows hypovolemia. The blood pressure is low, the heart rate's high. The sodium, what does that suggest? It's concentrated from the fluid loss. And then you look at, what does furosemide do? Well, it worsens the volume depletion. So what's your next best thing? You're going to hold it. I'm going to hold this diuretic and I'm going to notify the provider because you always want to assess fluid status before giving diuretics. Okay. All right. Electrolytes. So here's the patient scenario. The patient's potassium is 3.0. So that's low. The patient's magnesium is 1.2. That's also low. And then you have an order for IV potassium replacement, right? So you're going to ask yourself, um, which lab is abnormal? Well, actually, both of them are abnormal. The potassium is 3.0, the magnesium is 1.2. And so what should be corrected first? Well, the magnesium. And why is that? Because potassium will not stabilize without magnesium. So you're going to notify the provider and you're going to request a magnesium replacement first. Now, I know you're saying, wait, hold up. I'm going to tell the doctor what to prescribe. Well, there's a way of doing it. You can say, hey, doc, I see the potassium and the magnesium, are both low. And I remember when I was in school, they drilled us on make sure the patient has the magnesium. So does that fit here? All righty. And then they'll be like, oh, yeah. Think about it. Sometimes doctors are sleep deprived, they're working lots of hours, and sometimes they miss things. So we are there to be the last line of defense for our patient. So think of it like that. So, because remember, if the magnesium is low, and there's only a potassium replacement, it's not going to be it's not going to be effective, so it's going to be ineffective and unsafe. Okay, so always think safety first for your patients. Let's move on to scenario 4. All right, so we have some ABGs. So the pH is 7.28, that's acidic. All righty. The PaCO2 is 58. The bicarb is 26. The oxygen is 66. Respiratory rate is 10. And there's increasing lethargy. All right. So let's think this through. The pH is normal. Nope. It's acidic. Um, which value matches the pH? Well, let's look at it. The PCO2 is 58. So that means that the patient is retaining CO2. And if you remember looking at another video, CO2 plus water is carbonic acid. So, and then the CO2 takes place in the lungs. So the patient has respiratory acidosis. Is the patient compensating? No. You look at the bicarb. Bicarb is normal. Normal between 22 and 28, you know. So it's normal. So the patient is not compensating. And so now the O2 saturation is 66. Man, their O2 is tanking. Respirations are 10, and then their increased lethargy, right? So what are you going to do? Well, you're going to assess the airway and support breathing immediately. Ventilation and oxygenation on this patient is crucial. You have to think of um, this patient may be in respiratory distress or respiratory failure because of maybe we can guess, just say an opioid overdose, because this will happen. They'll stop breathing, the breathing will go down, the oxygen will go down, they'll be holding in that CO2, and they'll have respiratory acidosis. So remember, loss of compensation. So we remember the bicarb, they didn't compensate, and that falling oxygen will create impending respiratory failure. Okay. All righty. So let's look at the last scenario. Your patient has a creatinine of 3.4. Their urine output is declining, and you see an order for a standard dose IV antibiotic. And the reason why I put standard dose is because as you learn, you'll see when a person has kidney insufficiency, they won't clear those medications as well, and there'll be drug accumulation. So they'll alter the dose. So they'll lower the dose because they're scared of that accumulation. So let's look at it. So the labs, we already said, what would the medication affect? Um, the creatinine. So the labs will affect medication safety. I guess that's the best way to say it. And then what risk does this create? Well, like I said, drug accumulation. The kidneys aren't working as well. Drugs will have a tendency of not being cleared, so they'll accumulate and lead to toxicity. So what's the best thing you're going to do? You're going to stop. You're going to question the dose. Is this dose right? It should be a little bit lower, right? And then you're going to notify the provider. Remember that renal function must be considered before you administer medications. Remember that. Okay. So, you know, think about this. When you're in doubt, you just slow down and you ask the questions that we started off this video with. What is the most dangerous lab pattern that you see? Which organ system is at risk? Does the order correct or worsen the problem? What action will prevent harm to your patient right now? If you do this framework, it works for everything. It works for labs, it works for medications, fluids, ABGs, priority questions. It works. So if you just remember, this will help you be able to prioritize and figure out, because it's all about critical thinking. It's all about clinical judgment. And that is what the NCLEX tests. So like I said, what is the NCLEX really testing? It tests judgment, not task. It wants to see if you're going to be able to recognize harm. Can you prevent harm? Do you know to pause? Pausing is a skill. Holding waiting, notifying the provider, that's a good thing. Because if this is going to cause your patient harm, pausing is a skill. And safety always comes first. If everything that you do, it's like, well, I was protecting my patient, and you're documenting why, and you're calling the provider. That is our job. Okay. So that's really it. Um, just a little nugget for you. These scenarios, I wasn't trying to make them challenging, but I wanted them to be clear for you so you can see the pattern and what the exact goal is. Because this is how the NCLEX wants you to think. They want you to be calm, they want you to be logical, and they want you to be safe. Okay? So subscribe if you want more exam-focused nursing education. Download the workbook at NurseEdScholar.com. It's coming soon. And, I'm really doing all of this so you can study smarter and test like a pro. So until next time, happy studying from Nurse Ed Scholar.